Good Saturday morning to everybody, and welcome to HyperFit Radio with Dr. Charles Guglin, Francesca Guglin. I'm Gary Byron. Good morning, folks.
Good morning.
How's everything? Good. How's it going?
It's good. The world is warming up.
Yeah, slowly, but
slowly but surely.
Well, we're heading in the right direction anyway.
Absolutely. Yeah. And I usually get up. I usually pop awake at 5:30, 6 o'clock, and there's actually the world has
Days
light.
are longer.
Actually has light in it. You know, it's not completely dark when I get up.
See,
so
now
it's nice.
I'm going to ask you why you get up so early. You know why I get up so early, because I get on the air at 6 o'clock in the morning. But I don't see it light in the morning yet. I do notice it light in the staying later out in the evening. Mm-hmm. But what time is it? Because I'm being in this room in the studio here from 5:30, 6 o'clock on. It's not quite light.
It starts at about 5:30.
Really?
Yeah, it starts about 5:30. By 6, the world is. You don't see the sun hasn't come up yet, but it's just about to pop.
Yeah. What are you doing up so early?
It's just when I get up.
We have a whole routine now.
You get up. You get up and exercise or eat breakfast.
Exercise. Now we're doing a new thing: celery juice every morning.
Ooh, celery juice, huh?
It's a great detoxifier.
Well, I used to work at Fox 61. I was there for about 9 years, and I worked with a gal who bought. I don't know where she bought it from, but she was drinking wheatgrass, and she goes, "Ooh, it's really good." And I'm like, "Are you? What?" She goes, "No, it's exactly what you think it would be, Gary." And I'm like, "All right." She goes, "Have some," and I go, "No." She goes, "No, really, have some. Take one sip." And I fought it left and right until finally, she called me every name in the book. I was afraid. I don't take risks. I don't take chances. I'm like, I'm not daring. I'm like, fine, give it to me. And I took a sip, and it tasted exactly how it sounds.
Right.
It was absolutely disgusting. And she would drink this all the time. She chugged it. She loved it. And of course, it made me think, do you really like it? Can anyone really like this? Or are you just drinking it for other reasons? Because it's good for your body.
Anybody who tells you that stuff tastes good is just lying.
Yeah.
They're drinking it for health.
It's just supposed to take on an empty stomach too.
Oh, drink it on an empty stomach?
Yeah, first thing in the morning.
Oh, okay.
It's a tough way to start your morning.
It'll wreak havoc on your insides, huh? Well, that's the last thing we need to do that, especially coming into the radio. Ryan looks at me and is like, "No, please don't do that." If you remember last, you know what? By the way, we got a question in our mailbag. Maybe I'll wait until the very end to do that because I kind of wanted to pick up where we kind of left off. I think last week we were talking a little bit about menopause, although the mailbag question is about menopause as well. But we didn't get into last week the hormone replacement therapy and really how it's done.
Mm-hmm. Well, there's lots of different modalities that are used. Well, first of all, we were talking about women last week. Men, we've already talked about testosterone, which is pretty simple. It's pretty straightforward. With women, there's lots of different modalities. First of all, you have to understand that you're talking about 3 separate hormones. You're talking about estrogen in the form of estradiol, and progesterone and testosterone, all of which in an appropriately run program are what we call bioidentical or isomolecular. They're exactly the same molecules that a woman's body cranks out for all those years between menarche and menopause. And estradiol, for instance, can be given as a topical cream, or it can be given as a pill or a capsule that they take once a day. Progesterone, for the most part, is given as a capsule that is taken before bed because it's really good for sleep. Progesterone is very helpful. One of the principal complaints that we hear from women who are either perimenopausal or in menopause is that they have a lot of difficulty sleeping. The classic pattern is I fall asleep, I have no problem falling asleep, but somewhere in the middle of the night between like 2 and 4 a.m., I pop awake and I'm just done. I can't get back to sleep. And progesterone is very helpful in that regard. So typically they take it right before bed. Testosterone is typically given as a cream, a little bit of a cream that they put on their skin on a daily basis. Any of these, for instance, testosterone can be given as a shot once a week. Estradiol is typically given as a as a cream or a capsule that they take at nighttime, or they take any time of day. The key is really to take it at the same time of day. And any of these can be given in pellet form, although I don't particularly like using progesterone in pellet form because,
What are pellets? What's pellet form?
Pellets are the hormone in a compacted form. Typically, it's compacted with either cholesterol or just in its own base, where you take a little and make a little incision on the buttocks, on the fatty part of the buttocks, and you insert these pellets, which basically bleed hormone over a 3 to 6 month period. So kind of, in one sense, it takes the daily administration of these hormones off the table. It makes it easier in terms of administrating them. But by the same token, there are some downsides to pelleting. One of which is that typically you get once the pellets are in there, the blood levels of those hormones get pretty high for that first month. And so typically you're dealing with the symptoms of too much hormones for that first month. For instance, if you put an estrogen pellet in a woman and those blood levels get too high, they may start spotting, which you have a woman who's like 10 years past menopause, and that's an issue. And then for 2 or 3 months, they have nice levels, nice plateau where they feel good, there's no issues, so on and so forth. And then you have a very slow decline over the next month or so where they're not feeling so great because their levels have dropped off over time. So you have 1 month at the beginning where there's too much and 1 month at the end where there's not enough. And I don't particularly like that aspect of it. Plus, another thing I don't like about pelleting is the aspect of not really being able to tweak it one way or the other.
Why would anybody then even opt for that when there's other options available?
It's a lot easier. Makes and people, the whole spotting thing that I talked about, there are a lot of women who don't notice those symptoms one way or the other, either the first month or that last month that we're talking about. And they just like the fact that they don't have to give themselves a cream or take a pill on a daily basis.
And that's really how hormones are taken, right? Either by injections or cream or a pill or...
Yeah, for the most part, yeah. I mean, those are the most common ways of administering these things. And there are different reasons to do so. For instance, you get a much more cardioprotective profile of estradiol when it's given by mouth, because that first pass phenomenon, when it goes through the liver, some of the metabolites of that first pass phenomenon going through the liver are much more cardioprotective than they are if you give a cream. By the same token, if you have a woman who is, let's say, genetically prone to thrombosis, there are certain clotting factors that can be abnormal from a genetic standpoint. Factor V Leiden is one of these, which is fairly common. If a woman is prone to clotting, then you want to give her topical estradiol because the oral estradiol will make them more prone to clotting. So there's aspects of history, aspects of genetics, aspects of how a person feels that help you make these decisions. Yeah, those kinds of things. Yeah,
what was that? We couldn't hear you.
Varicose veins is another.
Yeah, not so much the superficial ones, but deep vein thrombosis is a problem in some women. And those women, you definitely want to use a topical estradiol. So there's some decision-making along the way.
About testosterone, is it really necessary?
Oh, yeah, testosterone is very necessary. Many of the complaints that we hear are, for instance, I love my husband, but I'm just not interested in being intimate with him. And they know it's a postmenopausal problem. Testosterone and another hormone called DHEA, which is given, that's just a pill. It's considered a supplement in this country. Many countries it's a controlled substance, but DHEA in this country is a supplement. Those two together are responsible for libido in women. The ability to build muscle and maintain muscle mass. Testosterone is critical to maintaining muscle mass. Let's not forget that one of the things that happens in andropause and menopause is that without hormone replacement, we turn into an apple, don't we? We get kind of chubby we start gaining belly fat. We start gaining what we call gynoid fat, that fat that makes our pants not fit that we hate so much. Muscle mass is almost exclusively responsible for our resting metabolic rate, the number of calories that we burn on a daily basis. Post-menopause, women start losing muscle mass. We talk about osteopenia and osteoporosis a lot in this country because there's pills for it, because the pharmaceutical industry markets those pills to us. So we hear about osteoporosis and we hear about falls. But one of the reasons women fall and one of the reasons old men fall when they get older is because they've lost a significant portion of their muscle mass. And so they can't control their body as well as they could pre-menopause and pre-andropause. So testosterone is critical to maintaining muscle mass as we get older. So those two reasons alone are important. Testosterone is amazing for skin, for hair. You take a woman who's 5 years post-menopause, their skin is kind of dried out. The estradiol is very helpful for that, but testosterone is also very helpful for that.
You seem to equate testosterone with postmenopausal. Should it not be? Should a woman not start to take it as they're premenopausal and then start building from there rather than a shock to the system at postmenopausal?
A good question. Most of women's testosterone comes from the adrenals. Some of it comes from the estradiol is metabolized to testosterone as well. So as their ovaries stop making estradiol, the testosterone levels in their system drop off. Mm-hmm. So that's one of the reasons why we start postmenopausally to administer testosterone, because for the most part, if you do blood work on a premenopausal women, their testosterone levels are pretty good for the most part.
Are there any risks associated with taking testosterone?
Acne for the most part is.
Okay.
Yeah. If a woman had acne when she was in high school, or when she was an adolescent, then if the pendulum swings a little bit too far in terms of their serum level of testosterone, they can start to have acne problems.
How can a woman who is on hormone replacement therapy, how are they expected to feel? Will it affect them in I don't know, in how they feel about their body, or I don't mean just mentally, but physically how they feel?
Well, tell them. Why am I answering this question?
Well, your energy comes back. You premenopausal, you're tired, you get night sweats, you can't sleep, you start with insomnia. When you're on hormones, your libido comes back, your breasts come back. You're able to build muscle at the gym. You see results when you're working out. There's a big difference being on hormones and not being on hormones.
Yeah. Remember those days when you could skip a meal and lose 5 pounds?
Oh, right.
Those days come back because that's pretty much, for the most part, hormonally driven. One of the things, obviously, one of the complaints that we hear the most is that I'm doing my best. People always say, I go to the gym 5 times a week and I'm getting fat anyway. And you and I know, you from your own personal journey, and I as a physician in my own personal journey know that maintaining weight maintaining fat loss or losing fat has much more to do with what you do in the kitchen than what you do in the gym. We know that, okay? And which is one of the things that we preach in our practice. But without being hormonally balanced, or what we call hormonally optimized in that postmenopausal phase of your life, you can't get there. You just can't get there. You can try. You can starve yourself. But when you starve yourself, you lose muscle mass, and then we're back in that vicious cycle that we were talking about before.
Oh. I know we're talking about women, but men could also get hormones in there, right?
Oh, absolutely. We did a whole show about testosterone, and it's the same thing, basically. The only difference between women and men is that men go through andropause over like a 10 to 15 year period. So we just get fat and angry for the most part.
Starting at like 40?
Yeah, in their 40s. Yeah, their 40s. You start to see, we're going to talk about erectile dysfunction next week, I think, but you start to see problems with erections in men in the 45 to 50 year range. And Although testosterone is not a treatment for erectile dysfunction. We'll talk about that when we get to it. But you start to see the symptoms of burgeoning andropause in men in their middle 40s, for the most part.
Talking about hormones and taking testosterone and estrogen, just any of these hormones. I think the question I just asked you, if you feel it physically or does it have any mental impact on you or anything
Everything,
like that?
I think.
Yeah.
It's a one of the questions I get asked a lot is, how long do I have to do this?
Well, yeah, and that was actually my next question as well. How, once you started, is this something now you're making a lifetime commitment to? And if so, are you increasing the dosage as you age?
Okay, the answer to the first question, and my smug doctor-ish answer to that is, how long do you want to feel good? Because quite frankly, optimizing a person's hormones postmenopausally or post-andropausally brings them back to where they were in their 30s and 40s in terms of how they feel, how their body works for them, so on and so forth. And the answer to the second question is no. Once you get somebody optimized, pretty much the doses that they're taking, for instance, when we are starting with somebody, we'll do blood work every 6 to 8 weeks until we get them optimized, get them feeling good, get them doing what they need, what they want to do, reaching their goals, in terms of they're working towards reaching their goals, that kind of thing. Then we broaden the time between blood work down to like a couple of times a year. Because once you've reached a dose, the rest of it can be dealt with by phone call, by text, by email. Because if a woman texts me, and I get texts about this a lot, or I get an email or a phone call about, well, my nipples are tender, my breasts are hurting a lot. Nobody, I can't even touch them. They hurt in the bra. We know that their estradiol levels have swung a little bit too far up, and we can tweak that dose down until they're feeling better. Another reason why pellets are a little bit of a problem, because if they have those symptoms while they have pellets in, there's not too much that you can do about it. But if they're using creams or pills, you can always move those doses so that they feel better. So,
how long? You said optimized with these blood tests. You said every 6 to 8 weeks or whatnot. Yeah. How long does it take to get optimized till you know that this is where they've peaked, this is their level, this is where it should be?
A lot of it depends on how long postmenopausal you are. Let's say you're 5 to 10 years postmenopausal. Don't forget that every single cell in your body has receptors for these hormones, okay? But we lose the receptors as we lose the hormones. So you need to build those receptors back again. So the new presence of these hormones in our bloodstream, our cells start to see it and start to build receptors. So in terms of optimizing, the process is a 6-week to 2 or 3 month process. A lot of women are very sensitive to these hormones, and so you got to there's a very narrow margin in some women that has them feeling good, getting where they want to go in terms of their goals, and so on and so forth. And so, a lot of practices, a lot of people have been doing this a lot longer than I have. Sure. Okay, there's real gurus in this business who've been doing it for 20, 30 years, don't even do blood work because they talk to their patients. Go figure. They talk to their patients, right?
We talked about that before, yeah.
They'll spend 15 minutes talking to their patients, and they adjust based on how their patients feel, okay? And I'm sort of working towards that in my own practice. I do like, though, I'll confess to liking seeing that blood work. I like to see that blood work because I think patients respond to the fact that there is some objective data out there that's helping you make decisions for them.
I asked you this, mentally speaking, the hormones and how it makes them feel physically. But what about medically? Is it safe, medically speaking?
Oh, absolutely. Yeah.
Take hormones.
The science has been done. The science has been totally done about this stuff. It is cardioprotective. We already talked about falls.
Mm-hmm. Yep.
There are actual medical practices out there that call themselves osteoporosis practices that basically administer calcium, vitamin D, and these pills I'm not going to mention the pills, but we all know what we're talking about because if you watch the evening news, there's 15 commercials on about these pills. Yeah. When in fact, the only real way that you can take a woman who's osteopenic or osteoporotic and help them turn that corner to making new structural bone is not by feeding them calcium, because the American diet has tons of calcium in it. There's absolutely no reason ever to take calcium supplements. Vitamin D, yes, and optimizing hormones, especially estradiol and testosterone. If you take a woman and you optimize their hormones back to where they were in their 20s and 30s, okay, and you have them doing some exercise, axially loading their bones, we do DEXA scanning. We have objective data that clearly shows that these women are turning their osteoporosis around and they're getting new structural bone back. In terms of risk, you asked about risk. I got off the subject. There is, if in a woman who has had breast cancer, okay, and is not a clinical cure yet for breast cancer, there is a risk for breast cancer. There is a statistical risk for breast cancer to return if you have a woman on breast cancer. If you have a woman,
what if she doesn't have breast cancer and never diagnosed with it, but it runs in her family?
It depends. If they're BRCA positive, if they have a genetic propensity for it, then quite frankly, it's more of a medical legal problem than a medical problem. Okay? Because we surveil women very closely in terms of breast cancer. And don't forget that 1 out of 8 women in this country get breast cancer, okay, whether they are genetically prone to it or not. Okay? So if I have 100 women in my practice on hormone replacement, 12 of them are going to get breast cancer during the period of time that they're working with me. And somebody in their family or their doctor who is undereducated about this stuff is going to tell them, Dr. Guglin gave you breast cancer. You need to stop those hormones right away. It is not true. The science has been done about this stuff. It is safe. It is protective in many different ways in terms of, we talked about the cardioprotectiveness of it. Cognitively protective. One of the things I hear about all the time is brain fog, okay? I'm foggy all the time. I have to do all my work in the morning because in the afternoon my brain's just not working for me.
You're having a conversation and you forget the words. You literally...
I've done that.
Yeah.
That's not hormonal. That's just lack of focus.
Folks, you're listening to HyperFit Radio Show. Dr. Charles Guglin, Francesca Guglin, I'm Gary Byron. All right, what I want to do, because we're running out of time, we got less than 5 minutes before we got to wrap up the show and close it out here for the day. I want to go to the mailbag, if you don't mind. Somebody has, and by the way, if you've got a question for the mailbag, it's hyperfitradio@gmail.com, and I'll repeat that at the end of the show. Lizzie from West Hartford, she writes in to ask, I am 41. Is it possible for a 41-year-old woman to be going through menopause? The timing of my periods are weird, and I'm moody all the time. That's from 41-year-old Lizzie from West Hartford.
Well, the short answer to that question is absolutely. There is a chance that you are in perimenopause right now. The time in which a woman, or the age at which a woman goes through menopause is extremely variable. There are certain statistics that we look at. For instance, when did you go through menarche? When did you start your periods? Because of so many phytoestrogens and so many contaminants in the food that we eat these days, there are many contaminants in the food that we eat that occupy estrogen receptors in our cells and can start menarche at a very early age. We're seeing women, young girls, going through menarche at 9 years old, 11 years old.
Wow.
It's crazy. And so if a woman's gone through menarche early, they tend to go through menopause early. There's lots of ways of looking at it. Usually it has to do with blood work. But if she's still having periods, but her periods are weird, she may be in what's called perimenopause. She's not menopausal yet. She's maybe going through perimenopause.
But the moodiness, and I would imagine the typically hot flashes, right? This would also occur, I
Absolutely.
would imagine. This is all typical, and there's hope for her.
Absolutely.
And her husband, if she's married.
Yeah, right. Yes, if he's hiding behind the couch when she walks into the room, there's definitely treatment for it. The sort of the standard of care in the non-age management world is to put a woman like Lizzie, that's her name, right?
Lizzie.
on antidepressants, which is absolutely the wrong thing to do because it typically makes the symptoms worse. Progesterone is actually the treatment for that.
Well, what if she's already on antidepressants? Can you get her off of them? And
Well, if she's on antidepressants for those particular symptoms, I would take her off, yes. If she's on antidepressants because she's been on them for 20 years for depression, I wouldn't touch her.
or a lot of people are on antidepressants for anxiety.
Yes. Well, if the anxiety came with perimenopause, then we would, kind of, because the treatment for that is progesterone, quite frankly. And as we titrate up the hormones, we would talk to her about coming off the antidepressants. But if she's been on them for a long time for depression or anxiety,
Sure.
then we would just leave her on them and treat her symptoms.
You'd be able to communicate with her
Absolutely.
with her doctor that
I
prescribed
tell
that,
women
right?
all the time, hey, doc, give me a call. Can I tell you how many times I've gotten a call from a doctor in 5 years? 0.0, because they never call.
Something wrong with that picture, by the way. That's not how it should be. There should be, as we were talking about, there should be,
Collaboration.
really collaboration and communication as well.
Right.
Folks, if you've got a question that you would like to have answered by Dr. Charles Guglin on this very show, you can make up a name in case in case it's unique and you don't want anybody to know your business. That's fine. You could even make up the town that you're from. We just want to be able to call you something instead of hey you, right? It's very easy to do. Just simply email hyperfitradio@gmail.com. Once again, hyperfitradio@gmail.com. Who knows? Could be your question that gets asked on these very airwaves as soon as even next month. And if you'd like to get in touch with Dr. Charles Guglin and everybody over at HyperFit MD, you're located in Milford. You can do that very easily, my friends. It's simply go to this email address, hyperfitmd.com. Correct? hyperfitmd.com. I would start with the website, but I'm also going to give you a phone number as well. Write this number down, folks. Area code 203-890-9777. It's very easy. I'll repeat that one more time for you. Area code 203-890-9777. For Dr. Charles Guglin, for Francesca Guglin, I'm Gary Byron. Until next Saturday, have a good one, everybody. So long.